Good morning, my dear students. Today we are going to discuss about examination of the hand, and this is the second video of this video series. So in this video we are primarily discussing on the techniques of examination. So I hope you will have seen my first video which has given you a good introduction on hand examination. So now how are we going to start the examination of the hand? As for any examination, there are 5 prerequisites. So first one is you have to introduce yourself, then you have to get the consent from the patient. 3, you need to have a privacy, although this is hand examination, still that is important because the details of health is confidential. Then you need to have adequate exposure. So even for the hand examination, the ideally upper limbs need to be fully exposed, and then you need to have adequate light to carry out the examination. So after confirming that you have these 5 prerequisites, then we can move on to examination of the hand. But what you have to remember here is examination of the hand is a long process. But as we are concentrating mainly on medical students, the UA examination is very likely to be targeting on carpal tunnel syndrome if the given command is only the hand examination. But always you have to remember, rarely there may be different cases. So how are we going to start your examination? As for any examination, you have to begin the examination with a brief history, which we are going to skip in this video. Then you have to move into inspection. So what you have to remember is your inspection is not only the inspection of the given hand, it has to be the inspection of the whole upper limb and also the examination of the contralateral upper limb. And when you are doing that inspection, you have to inspect both palmar surface, the dorsal surface of the hand, forearm, as well as the arm. So in this patient, my interested side is left side, but I will inspect the both hands, both forearms and both arms. My main interest will be any obvious deformities, the skin changes, lumps, features of inflammation, finally surgical scars and signs of previous trauma or injuries. So in these patients, on the palmar surface, I don't see any surgical scars, and I see both thin and hypothin eminence are equally well developed, and there are no gutterings in both palmar and dorsal surfaces, and the forearm, arm also free of any swelling, lumps, surgical scars, trauma marks or features of inflammation. Then I again would like to pay your attention on possible surgical scars that you may encounter in hand. So there are a lot of surgical scars which are possible in the hand, and it's good that if you can remember the possible surgical approach to the hand pathologies. But what you must remember are carpal tunnel scar, which can be seen in this area, and the ganglion scars, which again can be seen in these areas or as well as in these areas. Then what are the other important abnormalities you may encounter when you are doing the inspection of the hand? So one will be atrophy of the thinner eminence, uncommonly the hypothinner eminence. You may see guttering in between metacarpus that is more obvious in dorsal surface of the hand. And you may see deformities like sword neck deformity of the fingers, bottinius deformity of the fingers, and also the mallet finger. And if the patient is suffering from rheumatoid arthritis, you may see complex deformities involving small joints of the hand. So those are the important abnormalities you may inspect during your inspection of the hand. So then you have to move on to palpation. In palpation, you again confirm the muscle mass of the thenar and hypothenar eminence, whether they are wasted or not, and you might check whether they are tender or not. And then again you can check for the gutterings in both palm and dorsal surfaces. Then there are few specific areas where you have to palpate and see when it comes to the examination of the hand. The one would be the first dorsal compartment, where you get hallucis longus tendon and the abductor hallucis tendon, because that's where you get the dequavariant tenosynovitis. So you might palpate over them to check for the tenderness, and it's very important you always see the face of the patient when you are doing that palpation. So other important area that you have to palpate is the area over the A1 pulley or area over the metacarpophalangeal joint. So that's where you get tenderness or nodules in trigger finger patients. At that point, you finishes your palpation, then you move into checking for neurology. For that, you have to get the hand into supine position, and then you will start your assessment with the sensory assessment. And your sensory assessment has two components. One will be touch, other one will be pain. For touch, you can use a cotton wool like this. For pain, you can use toothpick like this. But what is important is, when you are checking for sensation, it's very important you have to compare with a reference point, and it's also important to make sure that patient will be with closed eyes, and there should not be prompting questions. What you should do is explain the procedure to the patient and ask her to come out with a spontaneous answers if she feels the pain or touch, depending on what we are going to check. I will do the assessment for pain, but for the touch you will have to repeat the same thing with the cotton wool. So what are the two reference points that you can use on a patient? So it could be either forehead or it could be over the sternum. So this is how I am going to give the instruction to the patient. I am going to press this thing over your forehead. When you feel it, you have to remember that sensation, and then you have to close your eyes, and then I will be putting this on the hand in different places, and when you feel that sensation, you have to tell me yes. So when you are doing that procedure, there are few important things that you must remember. In other words, you should know what are the type of expected findings. Basically, there are two types of expected findings. One is the findings based on the nerves of the hand. Other one is the glove and stocking type of sensory loss. So we all know in glove and stocking type of sensory loss, the sensation of the whole hand is lost up to a particular level. So what is important to remember is the nerve pattern sensory loss. So what are the nerves that will supply the hand? We know it's three nerves, but there's a one special branch which we should remember. So three main nerves will be median nerve, ulnar nerve, and radial nerve. So you have to check sensation based on these three nerves, and then the special branch which you should remember is the palmocutaneous branch of the median nerve. So how are we going to check sensation? So you are going to check sensation for the median nerve, where you are going to put your prick over the palmar surface of the thumb or index finger. And when you are checking for the superficial palmar cutaneous branch, you have to do your pricking over the thinner eminence. The importance of this is, at least theoretically, this sensation needs to be preserved in carpal tunnel syndrome, as this branch run over the flexor retinaculum while rest of the median nerve run under the flexor retinaculum. To check the sensation for the ulnar nerve, you have to do the prick over the palmar surface of the ring finger, preferably proximal to the distal interphalangeal joint. So if you have to check the sensation for the radial nerve, the ideal place to check is the base of the snuff box. So you have to check it over the snuff box. In that way, you finish checking sensation of the hand. Then you have to check the motor function of the hand. So what are the important motor functions of the hand? That again, there are two aspects. One, we are going to check each and individual muscles or groups with specific actions, or else you may check the motor functions based on the nerves which supply. So if you are going to check for 3 nerves, the ideal muscle which need to be checked for median nerve is abductor pollicis brevis. So how we are going to check for that is with the pen test. So how we are going to do pen test is like this. We have to ask the patient to keep the hand flat over the surface while all fingers are nicely extended and on the surface. And you have to get the pen onto your hand and you have to give the instructions like this. You have to touch the tip of this pen with this edge of the thumb without flexing this joint. Okay, try this. Right. So this is how it should happen. It should be the radial border of the thumb touching the tip of the pen, which is directly over the thumb without flexing proximal interphalangeal or the only interphalangeal joint of the thumb. What you must remember is, in both positive and negative tests, the patient will be able to touch the tip of the pen, but in negative test there will not be any flexion of the interphalangeal joint. In positive test there will be flexion of the interphalangeal joint, as patient use flexor pollicis brevis instead of abductor pollicis brevis to complete the task. So that's how we are going to check for median nerve. But what are the other muscles or muscle groups you need to check is, again you can check the power by asking patient to press against your finger like this, and then adductor pollicis like this, then flexor like this. So, and then you can check the opponent pollicis by asking patient to make this move. So these are the 4 main actions which can be observed or checked in the thumb. Then what are the muscles or the actions that you can check in the fingers? So that is mainly the abduction and adduction of the fingers, and that mainly check the ulnar nerve function of the hand. So how I can do that is, you ask the patient to spread the 4 fingers against resistance. Do like this. So you are trying to make them close while patient is attempting to spread them away from each other. So then how I going to check for adduction is, you need to have a board like this which should have some friction over the surface, and then you will be keeping hand exactly like the patient, and you are going to use the same fingers to hold the board like the patient, and then you ask the patient to keep it tight, and then you try to withdraw it, and you will be repeating same between all spaces. So this usually give you a good idea about ulnar nerve function. Then what I'm going to check is the radial nerve function. So that is mainly the extension of the fingers. For that you will get the hand into prone position. And you have to ask the patient to extend fingers against the resistance. Extend the fingers. Right. So in this way you can check the radial nerve. You may check thumb separately. Right. So that finishes the motor assessment of the hand. Now we are left with special test. There are a number of special tests for the hand, and there are two tests which you must remember. One is Tinel test or Tinel sign. Other one is Phelan test. So how we are going to elicit Tinel sign is you have to get the affected hand into the supine position, and you have to identify the anatomical location of the median nerve. How we are going to do that is with anatomical landmarks. So what are the anatomical landmarks for the median nerve? So you have to get the distal flexor crease, and you have to get the extended thumb and extend it to mark the Kaplan's line. In that way you mark the flexor retinaculum over the carpus, and then you get the radial border of the ring finger, and these two will be crossing over the median nerve. So you will be tapping over the median nerve, and you have to ask from the patient about any pain or tingling sensation which is spread over the median nerve distribution. Then you have to do the Phelan test. The principle behind Phelan test is the maximum space in the carpal tunnel is observed during this neutral relaxed position of the hand. Both maximum flexion and maximum extension narrow the space within the carpal tunnel and aggravate the symptoms of carpal tunnel syndrome. So there are two ways where you can do Phelan test. Either you ask the patient to keep like this, or even like this. So whatever the way you do, what you have to ask from the patient is whether the patient perceiving any pain or tingling which radiate to the hand or sometimes proximal. Other important thing that you must remember is to confirm the negative finding, you have to keep the hand in that position for at least 1 minute. So in this way, we complete the hand examination, which is adequate at medical student level. But you always must remember there is something called double crush when it comes to the carpal tunnel syndrome. So if there is anything that arose the suspicion of double crush, need the examination of the thoracic outlet with relevant examination tests. Thank you.